working for them to help put this presentation together. So thank you. Tonight we have Mike Gittleman, MD, FAAP. He is a pediatric emergency room physician at Cincinnati Children's Hospital in Cincinnati, Ohio. He is a professor of clinical pediatrics at the University of Cincinnati School of Medicine, my alma mater, so very proud to welcome him. He completed his undergraduate work at Swarthmore College and his medical training at the medical school training. Is that just a little bit of a Freudian slip there. His medical school training at the Medical College of Pennsylvania. He completed his residency in pediatrics at St. Christopher's Hospital for Children in Philadelphia and a fellowship in emergency medicine at the Cincinnati Children's Hospital. Mike used to serve on the IFCK board, and prior to their formation of a council, he served as the chairperson for the American Academy of Pediatrics section on injury, violence, and poison prevention. He's currently the District 5 Vice Chair for the AAP. With the Ohio chapter, he's developed a statewide bicycle helmet intervention, a gun safety program in the pediatric office setting, a hospital-based safe sleep QI program, and an injury QI program for practicing pediatricians. His area of expertise in research has been to study the impact of screening and counseling families about injury risk in the office and in the ED setting in an attempt to promote safer behaviors and prevent future injuries. He has published his efforts extensively in peer-reviewed journals. Please join me in welcoming Dr. Gittleman.
Thank you, and I'm really excited to be here. All right, let me put up some slides. All right. Can everybody see these slides? Does that work?
Yep, looks good.
Okay. So we will do the best that we can in the sense of if any of you have any questions along the way, please send a chat or send something to Olivia, and so that we can help answer. This process is very, it's hard because you can't see people nodding. There's no interaction. So hopefully that we'll have a good discussion at the end. As you heard, my name is Mike Gittleman. I'm the past president of the Ohio AAP. I currently serve as the District 5 Vice Chair. And I'm going to be talking to you about something that many of you that are in general pediatrics know about, and it's more of kind of a review, but we're going to talk about social determinants of health and kind of a practical application on how to get this into your office setting. I'd like to thank our partner, the Ohio Department of Health. They've actually paid for a lot of the help that we've had in putting this program together, and so we thank them. Besides the Ohio Department of Health, I really don't have anything else to disclose or a conflict of interest. I will say that also the Ohio chapter of the AAP, who's helping me, and I'm giving this talk with them and for them today, has really been instrumental in not only this work, but a lot of the work I've been able to achieve. I will put a plug in for the Ohio AAP in that now that I'm a District 5 Vice Chair, I get to see a lot of the other chapters, and we are incredibly fortunate to have really one of the dominant chapters of the AAP here in Ohio. And if you're interested in any kind of advocacy work or getting more involved or great ideas, please get more involved with the chapter, because it's really done a lot to open up doors for me, and I know it has for a lot of others as well. So I figured we'd start today with a case, an unfortunate one. Unfortunately, the worst part about it is it's a case that I was involved with. But a newborn presents to their primary care pediatrician at 2 weeks of life. The child's full term, no complications. There was really no problems. The mom took prenatal vitamins. Her group B strep was negative. And unfortunately, she was lost to follow-up. And really, there were no further visits and a few phone calls that were made to her house, but unable to get in touch with her. Then I'm working in the emergency department, and EMS presents to the home of this child that's now 3 months of age, and the patient is pulseless and unresponsive, and they were found in the mom's bed. The child received cardiac resuscitation and CPR for about 30 minutes. There was no return of spontaneous circulation, and unfortunately, they were pronounced dead in our emergency department. Unfortunately, sleep-related deaths, so it is a top cause of death, especially for kids that are under 6 months. In fact, for African-American children between the ages of 1 and 2 months, it is by far a leading cause of death. And unfortunately for this family and this child, they lived less than a mile from our children's hospital. When in talking to the family, they had barriers, so they were unable to keep their appointments in that they had transportation challenges. The mother was trying to get back into the work environment. She had unpredictable work schedules, and she had other children at home, making it difficult for her to get to her primary care provider. She also said at her 2-week visit, she received no counseling about safe sleep. And the family also had no funds to purchase a crib at the time, and so that's why she was sleeping in bed with the child. So I want to talk to you a little bit about social determinants of health. So social determinants of health, a big definition is they're necessary resources like food, housing, economic, social relationships, transportation, education, and healthcare, whose distribution across populations really determines length and quality of life, which is really health outcomes. And if you look, many of estimates show that social determinants of health account for close to 80% of overall health outcomes. When I look at things like that, I say, wow, if I could do anything to help families, which is what I want to do through anticipatory guidance, social determinants of health play a significant factor. So unfortunately, giving you a horrific case that I dealt with, and unfortunately, we have about one sleep-related death that comes that's pronounced once a month in our emergency department. And so what I want to do today is to learn a little bit about 2 really important issues that affect childhood morbidity and mortality, understand the effectiveness of screening and counseling about injuries and social determinants of health in the office setting. And then I want to introduce to you Ohio AAP Quality Improvement Program that addresses these at well child visits that might make this a little bit easier for everybody rather than feeling this is a daunting task every time that we care for patients. So I don't know if any of you recognize Abraham Jacoby. He's like the father of pediatrics. He was president of the New York Academy of Medicine. And he actually said, it is not enough to work at the individual bedside in the hospital. In the near or dim future, pediatricians are going to sit in and control school boards, health departments, and legislatures. So even back then, Dr. Jacoby realized that our role as pediatricians is far more than just caring for patients in our own setting, that there are things in the environment that we can really help and adjust. So we've looked at, within our hospital setting at Cincinnati Children's, we actually asked hospitalized patients, what are some of their biggest concerns? And the 3 biggest concerns, more even so, the health of their child when they were in the hospital, was housing, transportation, and food. And these were actually some of the quotes that we got from individuals was, my window's broken, there are roaches, and my landlord isn't responsive. Or it takes about 4 hours for me to get to the pharmacy. I have to walk 2 hours there and 2 hours back. And I just can't do it. I don't have the time. Or when I was in the hospital, I had no money, no food, no gas. And it was just horrible because I was breastfeeding my other child, and I'm basically eating nothing but cereal before the doctor came in. So these are real examples of what our patients are struggling with on a day-to-day basis. So you might have seen slides like this in the past, but I think it's important for us to talk about equity versus equality. Many that work in hospital settings or institutions or even work with legislators, everybody always talks about equality. We need equality of healthcare. And so in reality, that's what families get. They get equal care even if the risk differs, and that's what causes disparities. So if you take a look at the three boys that are trying to see the baseball game, each of the boxes are exactly the same, but the heights of the fence are different. So although they all have equality of the box that they're given, they have disparities in being able to watch the game. What we really want is equity, which is an absence of avoidable differences among groups of people. And so this is achieved by matching the box to the specific need. So if you take a look at equity, some kids need larger boxes than other kids, and that provides equity and it helps us get rid of disparities. And so what we need to do is start moving towards justice, which is equitable care, which matches the need for resources, which is targeting these social determinants of health. And that's kind of where we all come in. And, you know, we always hear about health inequities, but if you actually look through the literature, these are real life examples. So, I mean, in education, African-American mothers with a high school education are 2.2 times more likely to have an infant die. Or income, those with low socioeconomic status is associated with many increased risks of diseases like heart disease, arthritis, diabetes, respiratory disease, etc. And access to resources, so those that are lower socioeconomic and or a racial or ethnic minority, unfortunately, families that live in those communities have less access to grocery stores with fruits and vegetables. A lot of the stores that they have access to have items with longer shelf lives, and as a result, they're not eating as healthy as in families that might live in more of a suburban area. So what are some of these causes of lower health equity? Well, it could be your social environment. So some families just lack community resources, or unfortunately, they might have community resources, but aren't tapped into them. We all know about adverse childhood experiences like ACEs. So some kids have really difficult problems in their life, and some kids are resilient, but others have more problems. And then discrimination. So unfortunately, that there's still a lot of discrimination in our society, and these social environments affect families and lower your health equity. There's economic environment, which can cause it. So your socioeconomic status and living in poverty gives you a lower health equity. And then even just your own physical environment. So you can be in houses, there could be mold, there could be roaches, there could be asbestos, there could be lead in a lot of the homes where families are living, or even in outdoor activities where there might not be playgrounds for them to play at. There was a study that we did at Cincinnati Children's, and we found kids living in an inner city close to our hospital, they had at least 2 times more access to a fast food restaurant than they did to any outside play structure in their environment. So when we start thinking about social determinants of health, we're talking about their access to health care. We're talking about their access to resources like food or legal care, the education status, their employment status, as we said, the environment that they live in. Also, their income, their insurance coverage, housing, racial discrimination, segregation, and transportation. And so just to even think of insurance coverage. So when the Obama law came into play, it was the first time in American history that we had no difference between African-American families and Caucasian families in their insurance coverage. So there are things that we can do through legislation and through caring for families that we can affect some of these social determinants of health. It's not this glaring problem that we can't affect. There are things that we can actually do, and they're simple things, and we're going to talk more about some practical approaches. Well, to shift gears a little bit, so social determinants of health affect kids in many ways. As we talked about, it increases the risks of families for disease processes, but it also increases their risk for injury. And these kids often have health inequities. They have lower socioeconomic status. The mom might have maternal depression. They have lower education. And for anyone that knows me or has seen me speak, or you even heard my introduction, I've spent a career trying to look at preventing unintentional injuries to children. Anytime I ever give a talk about this, I always put up the CDC's leading causes of death. And I'm sure many of you know this, but if you look between the ages of 1 and 44, unintentional injuries cause more deaths than all diseases combined. I mean, if you take a look at unintentional injury and intentional injury, such as suicide and homicide, it's 59% of all pediatric deaths. So if we can do one thing to affect our families, is affect some of these social determinants of health and prevent injuries from happening. I mean, just look, this is annually what happens in the United States. There are about 190,000 deaths. It's one person dies every 3 minutes. And the deaths are only the tip of the iceberg, where there's about 2.5 million hospitalizations. There's about 31 million ER visits. In fact, at my hospital, a third of the patients that I care for in the emergency department are due to an injury, and it accounts for about 10% of our hospital admissions. And, you know, we all want to try and improve the cost of care. Injuries cost about $670 billion in medical care and lost productivity, which is about 15% of all medical spending. And unfortunately, Medicaid and government agencies paid for about close to 40% of days children spent within the hospital. So again, I'm not going to get too much on my soapbox, but when we sit there and say, well, it's people have a choice, you don't have to wear your helmet, or you don't have to get on a motorcycle, wear your helmet, you don't have to put a seatbelt on. However, we're still paying for a lot of these on the back end, and so we do have somewhat of a say, especially with our pediatric patients. When you take a look at, you know, what the injuries are, I always look at it as injury is force causing damage to your body. So anything that's going to cause significant force, or it's going to happen very quickly, it's going to cause significant death. That's why motor vehicle collisions cause more deaths than any other injury cause, because cars go very fast, a lot of people have cars, and there's a point that we can only do so much. And so that's why anything we could do to make them safer, by airbags, by putting in seat belts, by making cars safer, all of those things can help reduce these injuries. But then you look at other causes. We already talked about homicide and suicide, but then there's unintentional suffocation, which goes a lot to the sleep-related deaths. Drowning and poisoning, again, those things, they don't have force, but they happen incredibly quick. In fact, when you look at drowning victims and they interview children that had a drowning event, they were missing from the mom's vision for less than 5 minutes. So these things can happen incredibly quickly, and it also depends on where you live. So you can imagine the drowning deaths are greater in an area like Florida than they are in Ohio, except for when summer comes, we do see a significant number of them. And unfortunately, when you take a look at the United States, our international age-adjusted injury death rates are not even close to areas like England, Netherlands, Australia. You know, if you take a look, we're closer to Nicaragua and Puerto Rico. So we are clearly not doing as well as other countries in being able to prevent these injury deaths. And so we need to start finding ways to improve. So I want to talk a little bit about, well, look, I don't think everybody is going to get involved in legislative efforts. I would love for people to write op-eds. I would love for people to go testify at the State House and be more proactive in these areas. You know, I'd love for people to get engaged more with their communities and work. But I will say one area that we all can be working on is screening and counseling about injuries and social determinants of health in the clinical setting. So I'm always asked, well, who should be doing this kind of screening? And, you know, pediatricians always feel that this falls upon them. Well, I can tell you that there isn't really any literature to say who's more effective in screening and counseling. However, I will say, using examples from immunizations and Reach Out and Read, most families want to hear preventative information from their pediatrician. They feel if the pediatrician is going to spend their time and talk to me about it, it must be important. In fact, it's really funny when I used to talk with, before we had booster seat legislation in our state, and I would talk to families about a booster seat, they would say, if it's not a law, then it must not be that important. And so families want some legislation to tell them that this is what they should be doing. They want to hear from their physician telling them this is what we would recommend. Not only do families want to hear about it, but it's really part of our job. I mean, really, AAP, surgeons, U.S. Preventive Task Force all recommend that we should be counseling families. And I don't think that this all has to be done by us, but I think some of the screening could be done by others. So, for example, if you use a tool in your office, home healthcare workers that go into the homes, they can help with some of that screening. In daycare settings, they can help with some of that screening. And then it condenses work for us when we want to do some counseling. And we'll talk more about that later on. But having standardized screening tools to assess risk and then tailor counseling is incredibly effective. So one of my residents, and now as a fellow, looked at it and found 20% of families report at least one social risk in their primary care office. And Sarah Denny, who works at Nationwide Children's, we did a study that she had published in 2019, and we found families with children between 0 and 5 years of age, each one of them had about 4 to 5 injury risks at each visit. So there are problems that we are assessing once we ask them the appropriate questions. Well, why aren't we doing screening and counseling effectively in our clinical care setting? Well, one reason is that a lot of us don't receive a lot of training on it. I could tell you in my residency, unfortunately, I received one lecture about car seats. It was at my noon lecture. I was actually running late. I was trying to eat lunch. I was trying to go through my charts, and I was getting a lecture about car seats at that time. I received 5 lectures on pertussis, 5 lectures on meningitis, 5 lectures on croup. So the infectious diseases were emphasized. However, injury and the social determinants of health were not emphasized as readily. We also know that if Martha Wright up in the Cleveland area, she did some research, and if you don't receive training about it, you also will not counsel about it. So being able to have some information really helps you to be able to have appropriate conversations. It improves confidence, and it also, instead of giving anecdotal experiences, you can actually give recommendations based on policies written by the AAP. Speaking of policies written by the AAP, well, the other issue is we don't have time. I mean, I know in the clinical care setting, there's a lot of competing interests. You know, the parent might come in and say, my child's having problems with development, my child's having problems in school, my child's having all these other issues, and they're not even thinking about injuries. Also, there was an interesting study, it was in the mid-2000s, pediatrics, it was published in Pediatrics, and they found that there were about 57 AAP policies with 192 discrete health directives, and 2/3 were injury. So when I worked for the Council on Injury, Violence, and Poison Prevention, we would be writing policy every year, and you could see in this little graph the bluish, kind of purplish boxes where we would add policy. So when Heelys came out, that were the little wheels on sneakers, or when scooters were being used more, they would say, you need to write a policy on that. Unfortunately, we would add policy and recommendations. However, we would not take away anything. And you can see the red bars, we just kept increasing, and you need to talk about more and more and more, which made it very difficult for us in the clinical setting. Another issue is we don't get reimbursed for a lot of this work. I mean, you might get reimbursed for maternal depression screening, but you're not getting reimbursed for counseling and screening for injury, which is something that we need to start working on from an advocacy perspective. And there isn't a lot of standardized tools. A lot of people have anecdotal experiences of tools, or some have developed and used them in one setting, but there isn't a lot of standardized tools that have been developed and studied. The other thing that is frustrating is that if you take a look, this was a study that was done by Chen, and it was published in Pediatrics in 2007. And so what they did was they asked families and they said, did you receive any discussion about injury prevention anticipatory guidance at your visit? And they called them after their visit. And they repeated this study in 2007. And if you look in 1994 and you compare it to 2007, there was no difference. So over that time period, we have seen a reduction of deaths due to infectious diseases. Immunizations work. We've also seen a very slight decline of injuries because we are learning about injuries and more preventive devices are being developed. However, because infectious diseases have declined significantly, the percentage of deaths have increased because of injury. However, our discussions with families haven't changed very much. So that is one of the reasons I want to have this talk, and we want to kind of share some of the tools that we've developed. And the other question is, some might say, is this even really effective? Like, am I going to spend my time talking about injuries or talking about social determinants of health? Will it even make a difference? Because many feel that when they talk to a family, the family says, yeah, I know that already. Well, one thing is that some families don't know all the information. So if you are counseling to them, then they might just be getting education, and they're going to at least be able to make their own decisions based on the true information. So for example, we used to have the Back to Sleep campaign, but in the mid-2000s, the AAP came out with other sleep recommendations, which is the child should be in their own environment and with nothing else in the crib with them. So by educating them is one thing. Now, how do I change their behavior is a different question. But if you take a look at it, just by educating them, you're increasing their knowledge, which is far more than anything else. But we have also shown through a lot of research that families do change their behaviors when they're counseled about injury. So many will increase their motor vehicle restraint usage. Many will check their hot water temperature heaters. Many will adjust their smoke alarms. Many will change their safe sleep. And as a result, if they change their behaviors, they actually have a reduction in injuries. And we've seen reductions in falls and home injuries, as well as automobile injuries, just by families getting anticipatory guidance. And so what I want us to start thinking about is we need to try and assess risk in our office setting. And, I say office setting because, as we're talking about, if social determinants and health and injuries play a significant role in the health outcomes of the patients we care for, then this shouldn't just fall upon the general pediatrician. We should be doing this in emergency departments. We should be doing this when they're going to see a neurologist. There are things that we should be looking at, or at least being able to screen and provide resources. So one of the important things is we can all assess risk. We can look at employment. We can look at their education. We can look at their injury risks. Then we need to determine, well, based on their risk, what are some of the resources and how do I match them up? And that's somewhat of a difficult task, but we're going to show you a way that we've been working on this to make it a little bit easier. So, and as I said, I'll wait till the end to get some questions because it's just, I'll get through the presentation and then I'm happy to answer more questions for you about any of the things that we've talked about. So hopefully in this beginning part of the presentation, I've at least emphasized that, look, we should be doing something about social determinants of health and injuries and the risks that our kids face. Counseling works, but now, as we talked about, I don't have time, I don't get reimbursed, there's too much for me to talk about. How do I do this with a practical approach? And that's the next couple slides that I want to talk about with you. So again, I was very fortunate to work with the AAP to develop an injury prevention program with families in the primary care office. It was really exciting because this is something I wanted to do for a long time. I brought my passion to the Ohio AAP, and we worked together with experts nationally, and we developed a screening tool with talking points for kids birth to 1 year of age. We developed a QI initiative, and we studied it. We studied it. How easy is it to implement into practice? How reliable are the questions? Do families change their behaviors? And what we found was the tool was easy to implement within 1 to 2 months. Every pediatrician was putting it into their practice consistently. It actually reduced the amount of time that pediatricians were feeling that they were talking to families because you only had to address the tailored messages. So you weren't having to talk about 16 different things. You might find that the family's doing 13 things right, and they really only need to talk about 3 things. And so why should I be talking about things that they're already doing and they know about? I should concentrate on these areas, which they don't. And what we found in our study was 65% of families reported at least one behavior change after being counseled in their pediatrician office. And which is exciting thing is that after showing this, we've spread this program through other AAP chapters. And now we have, I think, 47 different states use this tool. Israel uses this tool, and a chapter in Canada uses this tool. So this is how one simple initiative can expand and actually improve the practice that we provide. Another program is the SEEK program. It was developed at University of Maryland, and it was really a tool that was used to screen for home social risks and social determinants of health. And really what they wanted to do is look at unemployed and lower socioeconomic parents for kids to prevent premature child death. And so their tool had a lot of discussion or questions about social determinants of health, and it had a few injury questions. But what the SEEK program found was that there was no additional time that the provider had to put in. They had fewer child protective services reports, fewer instances of medical neglect, fewer children with delayed immunizations, and fewer instances of physical assault with the families that went through the program. So in 2017 and 2018, our chapter at the AAP decided, you know what, this is something that we can actually affect. We've been very successful with our injury prevention program. Social determinants of health is another area that we have a difficult time screening, and they are somewhat linked. How can we screen for both using a tool and make it not too cumbersome? So what we did was we combined the injury prevention tool and the SEEK tool, and we condensed questions and we merged a lot so that there weren't a significant number of questions. We used the same QI methodology as we've had in the past, and we had 2 waves that were 6 months each. One was July to December in 2017, and one was January to July in 2018. Like most of our programs, if any of you have participated, we had physicians self-select to participate. They received MOC4 credit for participation, and we then, at the end, we started to compare the injury prevention risks and the social determinant of health risks and the resources that were offered. So you can see this is the tool, and you can see the areas of social determinants of health that we ask about and the unintentional injuries that we ask about. The tool is for birth to 5 years of age, and we talk about childcare, employment, utilities. There's a column on the tool for inappropriate responses. So the family answers questions. Based on the questions, we then would say, boy, this is a question they should have said that they do this all the time, or they should have said that they never are depressed. And so there's a response that we should address. We then have them check that response, and then the physician gets it and says, here are the specific talking points that match up with that inappropriate response. So even if you weren't sure what to say, so this family has a firearm in the house that is not locked away. Some physicians might not even know how to have these conversations. We put talking points that addressed each of these kind of problems that a family might say that they answered inappropriately. And then we developed regional resources based on what their responses were. And we did it at the county level. There are 88 counties in Ohio, and we matched every resource in the county with what someone might need based on the screening tool. It was actually really fun because I got to employ my daughter when it was a college summer program. And so she actually got to put a lot of the resource lists together. And it's fun to see that it's still being used with this program. And when physicians signed up for our program, they received tools, they received talking points, they received all of the county and national-based resources, and they also received assistance from our program manager, such as Olivia and Haley, who are on this call, that help really give guidance on how do I capture the data, how do I streamline this in my practice, how do I be able to look to see what my results are to make sure I'm doing the job I should do. Our QI programs, typically we try and come up with a core team, which is made up of a nurse, a physician, and an administrator at the practice. We have found that a lot of the time when a physician tries to do it all on their own, it can be somewhat complex because you need buy-in from the nursing staff, you need buy-in from administrators. And once everyone has buy-in and you change some policies within the practice, putting these tools into place is streamlined and very easy to do. We would have a pre-work conference call, so we'd be able to capture some baseline data and really go over quality improvement specifics. I mean, you can imagine in 2017, QI work was around, but not everyone had done so much. I'm pretty sure everyone's been involved with some QI program that's on this call, and so you already have a lot of that experience, so you might not need a lot of that pre-work kind of counseling. We would bring people together for a learning session that really talked about why the program's important. It talked a little about some QI basics, but then we really just reviewed how do you use these tools and how do you put them into practice. The other thing that this program offers is monthly action period calls, which really gave a 15-minute lecture by an expert about something that we're being taught. And again, as we talked about, the more you're educated about things, the more comfortable you feel to talk about it. So if you weren't as sure about safe sleep, we would have a 15-minute lecture on safe sleep, all of the literature, what works, what doesn't, how to do best counseling. And it made it a lot easier for people to be able to have the conversations. We also, during these calls, talked about the data and some of the pitfalls and successes that practices were having. As you can imagine, during COVID, when we run some of these programs, there was, as many of you remember, in March, April, and May, a significant reduction of families going to the office. And so when that was happening, what are some ways that we could overcome that so we could still give ancestry guidance, screen families, and even get them into the office setting? And then we ask for this program for 3 PDSA cycles, and we help you so that you can actually get this program streamlined into your practice. We collected data. As if anyone knows me, I feel pretty strongly that if you're going to put a program in place, you have to at least have some outcome that so that you can see that you're making a difference. And so we had practices randomly select 12 charts, 6 from each age group. We pulled charts to see what actually was being done at baseline, what discussions were being addressed, and then they submitted it into SurveyMonkey. And then we asked on a monthly basis, we pulled 10 charts, and now we have our staff at the Ohio chapter could pull them, or practices could do them themselves. And we would look to see, are we having more discussions based on what we're seeing within the charts? Then we analyzed the data from 2017, 2018 to kind of take a look to see what were we finding. The practices that participated, so we had 10 practices participate. There was anywhere from 1 to 4 providers in each of these practices. You could see they were in urban, rural, and suburban settings. But what was interesting was 60% had greater than a 40% Medicaid population. And what we found with this program was for kids birth to 1 year of age, at baseline, only 31% of SEEK injury prevention topics were being discussed. Most often, pediatricians are talking about back to sleep or car seat positioning. But then when we pulled about 300 charts and we reviewed them, on average, about 4 to 5 risks per tool were identified. And the most common were parents didn't know CPR, parents didn't get their car seat checked. And by the end of the collaborative, inappropriate responses that were counseled were done 83% of the time, which is 52% up from baseline. But the other thing that was really exciting was 60% or 63% of resources were provided to families that needed it. So prior, there was very little screening being done. Now, we're doing a lot more screening just by using this tool. There's significant more counseling, and families are now getting resources tailored to what their needs are. And when you take a look for the 1 to 5 year olds, we had very similar findings. Only 24% of the time were SEEK and injury prevention topics addressed. Many of them were like the ones that were addressed where they can't care for their child or maternal depression. But when we pulled charts again, there were about 4 to 5 risks per tool that were identified. And again, inappropriate responses for counseling were 86% of the time, 62% up from baseline, and 69% of resources were provided to families. The other thing that was interesting was we found that risks for injury in the 0 to 5 population were greater for unintentional injury than risks for social determinants of health. Now, there's some limitations in this. One is that these were not all in underserved populations, as well as sometimes in some of these populations, they might not feel as comfortable talking about social risks as they are about unintentional injury risks. But we still found 4 to 5 risks were being assessed every time a tool was used. So hopefully in this, I'll call dinner / after work discussion get together, primary care providers can implement tools to address injury prevention and social determinants of health risks. And that these tools can be implemented easily, quickly, and they can actually change practice to benefit our families. That we increased significant resources that were being provided, and that families with children less than 5, as I said, had a lot more unintentional injury risks and social risks, but both were identified significantly. So one of the reasons why I asked to come speak to this group is that we, through the Ohio Department of Health, received funding to continue this program. They were very happy that we were starting to show some change and that resources were being provided to a lot of families in Ohio. And so we are conducting a third wave, and we're building from our past experiences. We are adapting it so that we can, keeping COVID-19 in mind. So this new program is going to be all pretty much online. So the education is online. You can kind of go through the program at your own pace. You have resources of staff at the Ohio AAP to really assist and get you through the program, and you get the MOC credits as you have in the past. And then this will assist families with social supports, and now it's more important than ever. I mean, as you all know, poverty line is increasing. Many families are losing jobs. Many families can't pay their mortgages. And so we really need to be addressing this with our families now, really more than ever. And so if you are interested, you would receive, if you signed up, you would receive the coaching, you would receive screening tools, you would receive virtual education, You would have family incentives. So we give like sleep sacks and baby books and other things to practices that participate. And you would receive all of the local and national resources that you could provide to your families. So I would say if you are interested, you can contact Haley at this email. You can also go on our website and just look at the Injury Prevention Plus Speak and kind of learn a little bit more about it, but hopefully you learned enough here. We're hoping to launch things towards the end of this month, but as I said, you know, if you wanted to join the beginning of February and you go and talk to many of the other practices, or even if you are a practice but not a primary care physician, but you want to get more involved and care more for your families in this way, we'd love for you to participate. And in particular, we also have all of this information in Spanish, and the Ohio Department of Health is really interested in us and how this affects Spanish-speaking populations. And so if any of you are interested and have a very high Spanish-speaking population, let's talk, because we can actually even give more incentives to you for participating. So again, I hope that this talk really helps you understand that we need to address these social determinant of health inequities, and we need to start moving towards more justice of care. And these social determinants of health not only affect all of our patients, but they also increase our risks for injury. And for any of you that feel, boy, this task seems overwhelming, or how am I going to do this in the office? I can tell you that our staff can work with you, and it will reduce your time. It'll provide resources for your families, and your families are going to appreciate the visit because you're going to be giving them more than what they might have been getting in the past. And that this program is incredibly successful, and it can make a difference for the families that you care for. With that, I will open this up for questions, and I'll get out of the slide presentation.
I do have a question for this. Our large group practice, COPC, has recently, with the help of Dr. Adaman, who is on this call, instituted a pediatrician-wide social determinant of health questionnaire, and we actually were able to embed it into our EHR. Is the tool that you're using, is it a paper tool, or is it scanned in, or can it be dropped into the EHR? That was one of the struggles that we had that we were able to overcome. How did you guys do that?
Yeah, that's a great question. I mean, you know, what's difficult is everyone has different EHRs, and we're working with a lot of primary care pediatricians throughout the state. And I mean, even in some rural counties, they're still using paper charts. And so it's very difficult to try and be able to have a one-size-fit-all. I will tell you, like, for example, in our primary care practice in Cincinnati, they ask a lot of social determinant of health questions already that is geared towards their population, but they don't ask a lot of the injury questions. And so when I talk to them, I say, look, I understand what you have, but why can't we address it in a more comprehensive way? And it's not going to, it might add a little more time for your family to have a few check boxes, but we're actually going to be addressing things that we need to be addressing. And so what some have done is they've done dot phrases to be able to get it into their EMR. Some have, after they've done it on paper and they found it to be incredibly effective, then the next time that they got involved with Epic or whatever EHR you use, then they readapted and they put it into their record more permanently. I will tell you that one question which I get asked a lot is, you know, I'm told, look, my practice, it's only me, or it's me and my partner, you know, we're doing our best to see as many patients as possible. We feel that we do a pretty good job of this. And what we have found is when we actually have our team go in and work with practices to implement tools like this, at the end, they say, wow, this was really helpful. I'm so glad that I got involved in it. And actually, Haley's done a lot of work following up practices, and we found that still close to 60 or 70% of practices are still using some versions of our tool after they've done with the QI program. So it really goes to show that it seems like a hurdle at first, but it really isn't that much of a hurdle. And once you put it into practice, it's really simple to use, and your families will appreciate it.
Well, and what we found locally is that our local CAP for Kids, the Children's Advocacy Project in Central Ohio, capforkids.org, has a lot of those resources for parents. So when we determine that there is a need, we can just give them our list of resources. We circle the number on it and say, okay, so we see that you have this need. Here's a resource. Go to CAP for Kids. They also have provided us with material for in our offices as far as food insecurity and things like that. So it has been really helpful to have that local organization, which is vetted. I don't know if Dr. Emily Decker's on this call, but she tweets every day things to do for kids and resources that are available in Central Ohio. So that's been super helpful for us.
Right, and I understand that there's a lot of people have some version or a few things into place. And, you know, I think that's great and it's really important. But having a more standardized, comprehensive approach sometimes is, it could be more helpful. Like, for example, in our primary care clinic in Cincinnati, they have a legal aid that helps a lot of families. So if they're having a problem with maybe housing or food, they will be contacted to the legal aid and they're matched up to resources. However, they're not asking about safe sleep and a crib, and they're not asking about four-sided fencing and pools, and they're not. So although we're addressing some areas, and a lot of those started because of an interest of that individual that put it into the practice, but finding things that are more comprehensive and a standardized approach and adding that to what exists is sometimes helpful.
Hey, Mike, this is Kate. I'm trying to turn my video on, but maybe I'll come on or not. But you can hear me. I see you smiling. Yeah?
Okay. Yes?
Anyway, I was just going to say thank you. Thank you for giving such an excellent talk. But also, how can I get a hold of your slides for your presentation?
Good question is, I can send it to your group, and do you post these, or, how do you do this in the past? So, Eileen, do you know by any chance?
Amy Jo is our administrator. So if you can email those to her, she can email them out to the group. Yes, Amy Jo?
Correct. Yes, that's fine.
That would be great. Thank you.
And Amy Jo, I know that I think you have Olivia and Haley's contact information, and I'll add mine in the email. So if people have other questions or, concerns or want to learn more, we are incredibly available. And so we would love to help answer any questions to get people to start, putting this into practice.
And Dr. Gittleman, this is Olivia. There was a question in the chat box about how long would this waive rental?
I will leave that. Do you know, I think it's only 6 months. Is that correct?
Yeah, I believe so.
Olivia?
Yeah, and Haley might, if she's on, she might know even better than myself. Are you still on, Haley? Well, we can definitely follow up. I do believe, yes, if we kick off in February, I think it's supposed to be wrapped up by June or July, depending on, when they start submitting data.
And I'll tell you, the ask of the practice is pretty small compared to kind of what you're getting in return. I mean, they get sleep sacks, and you get a lot of things for your families. And you also get the tools, you get help from the project management team, resources. So it's really not a heavy lift at all. And you get the MOC credit for participating.
Great. Are there any other questions? No, if not, Mike, thank you. That was amazing and very pertinent to what especially our group has been doing over the past 6 months. So the next meeting, you'll see the next slide. Our next virtual COPS meeting will be on February 17th, also at 6:45, and it's going to be Dr. Timothy Smith, who's interim medical director of the Comprehensive Pain Management Clinic. It's going to be a journey through pediatric chronic pain. So I hope to see everybody there. And once again, it'll be virtual. I think that is the Chinese New Year. So maybe everybody just order out Chinese and have it, sent to your house. And maybe Amy Jo will go through what the year of, I don't think it's the year of the rat, but we'll figure out what year it is. And maybe we'll have a little drawing for a fun prize or something. And everybody that's registered, we'll just kind of randomly pick them out of the thing and then see if we can send you a little prize. So that concludes tonight's talk. I would say drive safe, but you don't have to. So walk safely in your office slippers, or my husband calls them his work slippers, to your next destination, which might be in the other room for dinner. So yeah, thank you, Dr. Goodman. That was great.
Yeah, and thank you for having me. We really appreciate it.